of the Department of Family Medicine here at McGill, and it is my great pleasure to welcome you all to the 2025 Dr. Hirsh Rosenfeld Distinguished Public Lecture in Family Medicine. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. I am a settler on this land, being born in what is now known as Canada to immigrant parents from colonial power countries, England and the United States. Je me joins alors à McGill pour honorer, reconnaître et respecter ces nations autochtones à titre d'intendant traditionnel des terres et de l'eau sur lesquelles nous nous réunissons aujourd'hui. So tonight, we are gathering not only to hear from an outstanding speaker on a topic that touches the heart of our work, recognizing and treating pain in primary care, but also to celebrate a very special milestone, which is the 50th anniversary of the Department of Family Medicine at McGill. Dans ce contexte, j'aimerais partager avec vous une vidéo.
La médecine de famille célèbre ses 50 ans à McGill. Half a century of enriching lives, forger des liens durables et créer des communautés en santé. Every day, our family physicians set out to help others. Our learners, although not yet doctors, are already inspiring change and making way for the next generation. They are our future. Nos scientifiques explorent les complexités de la santé humaine, jettent les bases des découvertes de demain et s'attaquent aux plus importants problèmes de santé de notre époque. As we celebrate our successes and learn from our past, we look forward to a healthier tomorrow. Célébrons 50 années d'excellence, de persévérance, de courage et de détermination.
For half a century, our department has been at the forefront of advancing family medicine in Quebec, in Canada, and beyond. We've grown from a small pioneering program into a vibrant community of clinicians, researchers, educators, and learners, all united by the belief that strong primary care is the foundation of a healthier society. Je tiens à souligner que cet événement ce soir est le fruit d'une merveilleuse collaboration entre le département de médecine de famille de McGill et le centre de recherche de l'hôpital de St. Mary. The St. Mary's Research Center is in the neighborhood of Côte-des-Neiges with a very multicultural patient population and strong links with the community. The St. Mary's Research Center has been a pioneer in primary care research for more than 3 decades, with a strong commitment to fostering patient-centered research and healthcare innovation. Tonight's lecture reflects exactly what our department and the St. Mary's Research Center have always stood for, a commitment to compassionate, patient-centered care, grounded in rigorous science and responsive to real human needs. Pain is something that every family physician encounters daily. It's complex, it's deeply personal, and too often is misunderstood or undertreated. Addressing this challenge requires the kind of holistic, interdisciplinary approach that family medicine champions. Alors que nous célébrons ces 50 années de progrès, nous nous tournons également vers l'avenir pour continuer à innover, à approfondir nos partenariats communautaires et à mener des conversations telles que celle-ci ce soir. So thank you for joining us for this important evening. For years, the Department of Family Medicine has also partnered with the St. James Literary Society to promote this event. Des partenariats comme celui-ci enrichissent notre travail et élargissent les conversations que nous pouvons avoir tant à l'intérieur qu'à l'extérieur des murs de l'université. And I believe that a representative of the St. James Literary Society, Kevin Journeau, is online. And Kevin, if you are there, would you like to say a few words of welcome?
Yes, thank you, Marion Dove. I am Kevin Journo, president of the St. James Literary Society. Welcome to tonight's lecture. Since 1898, the St. James Literary Society has been bringing speaking engagements like this one tonight, and I am proud to present this collaboration between the McGill Department of Family Medicine and the St. James Literary Society with Dr. Isabelle Leblanc. If you enjoy this event, consider joining the St. James Literary Society for our other upcoming events. Thank you and enjoy the evening.
Thank you very much. Il me fait un grand plaisir maintenant de vous présenter la personne qui va présenter notre conférencière ce soir. So Dr. Ari Megardichian is the director of the St. Mary's Research Center, and as a clinician, he is unfortunately now doing an emergency surgery, so he is not here to present the speaker, but we have a wonderful replacement. Alors, je vous présente Najia Hachemi Idrissi, qui est le PDG adjointe du CIUS Ouest de l'île de Montréal. So Najia, my pleasure, you can present Dr. Leblanc.
Bonsoir tout le monde. Alors, c'est vraiment un plaisir pour moi aujourd'hui de vous présenter la conférencière émérite Hirsh Rosenfeld de cette année, Dr. Isabelle Leblanc. Particulièrement as a chronic pain survivor, I'm really pleased to be here. Donc, Dr. Leblanc est médecin de famille en soins primaires, ayant d'abord suivi une formation en anthropologie et en littérature avant d'embrasser la carrière en médecine. Elle a complété ses études médicales à l'Université d'Ottawa, puis sa résidence en médecine de famille à l'Université McGill. Elle a rejoint le département de médecine de famille de McGill en 2007 en tant que professeure adjointe, et à ce titre, elle enseigne la bioéthique, la communication interprofessionnelle, ainsi que les enjeux sociaux liés à la santé aux résidents en médecine de famille. Dr. Leblanc est également membre actif des médecins québécois pour le régime public, militant pour un système de santé public universel et équitable. Elle enseigne actuellement à Côte-des-Neiges. So in 2022, Dr. Leblanc was awarded the competition attracting research excellence, the CARE grant, funded by St. Mary's Hospital Foundation for her research project with the title Too Much Pain Doctor, training clinicians to detect expressions of psychological distress in patients of diverse cultural groups. This research is a collaborative study involving Department of Family Medicine members Jenny Agerty, Elaine Adams, and student Madison Ligat. In the past year, Dr. Isabelle Leblanc was inducted into Academy of Exemplary Physicians for her outstanding contributions to patient care and education. She was also named a Family Medicine Hero by the McGill Department of Family Medicine for her continued advocacy for women's health on a global scale. La pratique et les intérêts de recherche de Dr. Leblanc illustrent parfaitement les valeurs qui sont au cœur de l'hôpital Sainte-Mary's depuis 100 ans maintenant. Offrir des soins empreints de compassion à ceux qui sont souvent laissés pour compte dans notre société. Et c'est pour moi un réel plaisir d'être témoin de cette collaboration fructueuse entre notre centre de recherche et le département de médecine familiale de l'Université McGill. Alors, Dr. Leblanc, merci.
Merci beaucoup. Ces mots qui me touchent beaucoup, en fait. Je vais juste vous dire quelques mots en français. La présentation va être en anglais. Je crois que la plupart des écrans vont être en anglais, mais je crois que celui là-bas est en français. Et on pourra prendre les questions en français là, à la fin. Puis, je vais essayer de faire ça assez court pour qu'on ait du temps pour discuter. So thank you very much for inviting me for that presentation. I was very touched hearing all the nice things that people had to say about me. It's very, just to get my composure back. I really, really appreciate being here. Thank you to McGill Department of Family Medicine, the St. Mary's Research Center, the St. James Literary Society, and it's interesting because I did start a PhD in literature. So literature is really something I find interesting. And as we talk about the subject of my talk today, part of it is actually about narrative. And part of it is actually rooted in a literary interest of mine. So I think it's very fitting. I'm just going to make sure I'm able to change the slides. There we go. Okay. So usually when we give presentations in medicine, we have to say if we have conflicts of interest. I never have any because nobody wants to fund anything of what I say, because I usually say to give less medications and to do less commercialization of care. But in this specific context, I have even less conflicts of interest to disclose. So I was thinking, so yes, I'm going to talk a little bit about pain, but it's not really a talk about pain management. It's a talk about what the doctor understands or doesn't understand when someone comes and says, I have pain, doctor. And the aspect I want to talk about is a very cultural aspect. It's about pain that's coming from more of a psychosocial, emotional, psychiatric kind of side of the body that actually expresses itself as physical pain. And every time I talk about the research project, or I talk about this talk, I always feel a bit uncomfortable because it's always like the other people that are not like me. When they come and talk about their pain, how do I get that this is not like physical pain? How do I get that this is psychological suffering? And thinking back, it doesn't always happen with people that are very different than me. So I wanted to talk to you about la crise de foi. So those of you who read French, like French literature, French comic books, all of that, there's always someone at some point who has a crise de foi. So there's usually something that happens and then they feel really unwell and they take to their bed and they mention that they have maybe to visit the bathroom often, but they don't say it in so many words, but it tells you something that they might have an upset stomach or something, often after something really bad happened in their life, and then they're bedbound. Marcel Proust, he had many crises de foi. Honoré Balzac, same thing. The newer writers as well. And even in Astérix et Obélix, the Abraham Raccourcix, who's the chief, like this in this comic book, he gets a crise de foi, and it's actually the heart of one of the stories. So I grew up with that, reading tons of books and hearing all the times about crise de foi. And then I go to med school, and then I do my med school, and then I go to residency training here at St. Mary's, where I'm now teaching. And then somewhere in my second year of residency, I realized that nobody ever taught me anything about une crise de foi. Like, I did not know what a crise de foi was. Turns out it doesn't really exist. It's what people feel. They feel really unwell. They have to take to their bed. They feel very, very tired. They have sometimes nausea. Sometimes they have gastrointestinal issues. But it's actually not the diagnosis. What in my mind was so clearly a thing, une crise de foi, well, it could be a migraine. It could be a panic attack. It could be, biliary colic when you have stones, in your gallbladder, but it actually doesn't exist. So everything we think about medicine and everything we think about our physical being is actually a little bit culturally mediated, because try to tell someone from France right now that crise de foi doesn't exist, it's not going to work really well. I mean, I have patients coming and see me and they're like, well, I need something for my crise de foi. I now decide not to address the issue and just treat whatever I think they have, because it's really something that's culturally really pregnant for them. So there were a few other issues now that I was a resident, and then as a staff, people coming with weird symptoms. What I felt was weird symptoms. Doctor, I have a swollen head. I was a lady from Egypt that told me that. And she was like, look, I have a swollen head. I didn't see anything. I saw someone who looked a bit, maybe tired, maybe a bit anxious, but her head wasn't swollen. And she was pointing somewhere. There was no swelling there. But it was her way of telling me that she was really, really feeling unwell, that bad things were happening. Her son was still in Egypt, had an accident, and she felt really, really well and really, really unwell. And her way of expressing it was, I have a swollen neck. Then another lady who came from the Congo was like, doctor, I feel like I have a fever. You can check my temperature. I don't have a temperature, but I feel like I have a fever. J'ai la fièvre, j'ai la fièvre. J'ai pas de température, mais j'ai la fièvre. She was feeling really, really hot and unwell and probably very anxious, but she felt that as if it was a fever. as a doctor, someone has a fever, you measure the temperature and you think about what infection or inflammation they have. You don't necessarily go and dig for, whatever's happening with, her status, like as a resident here in Canada wasn't approved and she might have to go back to the Congo. And she felt that as I have a fever without a temperature. And then my favorite, I saw her yesterday, poor lady from South Asia, often from, Sri Lanka or Southern India. I have too much pain, doctor. And they come and they sit and they really look in pain and they tell you I have too much pain, doctor. And I'm pretty sure anybody who's practiced here in Côte des Neiges has heard too much pain, doctor, right? It is something you hear very often. And these are people that are usually functioning, taking care of their family, often working, doing so many different things, sending money back to the country. They're functional. Like as a physician, when someone has a lot of pain or say that they have a lot of pain, you see how is this impeding their day-to-day function. Often these people function very well. They're just completely exhausted and they feel part of what's going on in their body and they have too much pain. And it's very easy as a physician to go down the road of let's check where the pain is coming from and let's, find a physical cause and hopefully there's a medication we can give and it's going to solve it all. But lo and behold, it's not that easy. So after a few years, of these happening and me doing all sorts of tests and looking at the patients and, sending them for a test and coming back and they have the same symptoms and trying medications and nothing really, really helped, I realized that there was kind of a pattern. It's often people that were from culturally diverse backgrounds, except for French people are not that different from me, but they had crise de foie and I couldn't manage that either. So I'm talking more about people with whom we have a bigger cultural difference, but it happens probably in a more subtle way in people with whom I have less of a cultural difference. And according to what we were taught in medical school, they had very vague complaints. Medical school likes to tell you that sometimes people are bad historians. They don't give you a good history of what's going on, like it's their fault. It's not your fault as a physician who doesn't ask the right questions, which I think, often if you ask the right questions, you will get, a better history, but it's often people that have very vague things that we can't objectify. You look at the patient and you don't see what the issues are, so it's something that's very easy to dismiss. And too much pain, Dr. Lady, which again, I saw like 2 days ago, yesterday, it took me maybe 4 or 5 years that, to get the reflex that when she comes and says, oh, I have too much pain, doctor, to say, okay, well, what's going on in your pain? And there's always something. And that pain, she feels it physically, but part of it is psychosocial. So it's really because of that lady that I decided to ask questions and figure out how we can train family physicians better in these things. So the background observations, just things that I think most of us know, but just to make sure it's said, it's explicited. Mental health can cause a lot of suffering, but it's often stigmatized, right? If you ask someone if their pain might be related to depression or anxiety, people feel that you're shutting them off saying, well, this is not real, right? It's the link between, we all been stressed, I'm sure, and had a headache because we were stressed. The headache was really, really real. The cause might be the stress, but the headache was really real. When it's hard sometimes to explain that to people because they're often told, they often feel that if you say this is, not a physical pain, it's not true, but it's actually true. Psychosocial distress can cause a lot of pain. We know that there's a higher rate of, undiagnosed mental health conditions in minority or culturally diverse groups because, well, a lot of people have undiagnosed issues, but it's even harder when there's a cultural difference. And there's a term that we use, which it's not always a nice term to use, but it's useful, I think, for those of us who could provide care to patients, something called somatization, which is when the psychosocial distress, the stress you're going through, the stress in your family, your mental health, other external factors lead you to feel real pain. And that's really important to say. This is really a real pain. It's not people pretending to be sick because they want this or that. They feel it. They feel it in their body, like we've all felt stress. Like right before this talk, I had little butterflies in my stomach. They were real. They're caused by the stress of giving a talk, but they were real, right? We all have those real symptoms, but it's called somatization, right? Because we feel in our body what's really going on in our mind or with our emotions. Family doctors, I wrote family doctors, but actually anybody who does primary care, so nurse practitioners, clinical nurse, anybody who does, midwives, anybody who does primary care play a crucial role in recognizing and managing psychosocial distress. If you're the first person people talk to about how they feel, you need to be trained and good at managing and assessing psychosocial distress. And there's tons of screening tools about, depression, anxiety, PTSD, all of that, but they're all very culturally biased. And they're not very good, even, for the majority of people to actually diagnose things, but it's even worse if there's a cultural distance there. And as I mentioned, the psychosocial distress can often be felt as bodily pain. It can be felt inside the body and very easily dismissed, unfortunately, if there's no real diagnosis that we find when we do all. So, as I said, we often miss the diagnosis of psychosocial distress when people present with pain, especially if there's a cultural difference. And medical school and residency is not very good at teaching us that, and it's really experience that gets you to learn how to do this. Some people maybe might gain it faster than others, but we have a lot of expert family physicians in intercultural, multicultural care here in Montreal. A lot of them in the McGill system, a lot of the others in the Université de Montréal system, but we do have a lot of people that are very, very good at that. And we thought maybe they can give us cues. Maybe we can talk to them and try to figure out a way of us being better at giving that care and improving how we teach family medicine residents and other primary care provider about that key issue of people presenting with bodily pain that's really related to psychosocial distress. So we have a great team. Most of them are here. Jeannie Haggerty, Lena Adams, Madison Legat. Our hypothesis was, well, there's this issue and we need to find a solution. The solution we thought was going to come from expert family physicians. So we felt and we thought, and that was really kind of a gut feeling that, well, expert family physicians, they found cues, they found ways of eliciting the fact that maybe the pain comes from psychosocial distress. And because these strategies are not taught in medical school, there's no formal mechanism to transmit that to the others. So if you're lucky enough that you have a supervisor who's really good at that, and you do your residency and you're taught by them, then maybe you'll get it. But otherwise, you're kind of reinventing the wheel where you're learning yourself and other people's. So we had three major questions for our project, which was, how does culture and gender change how psychosocial distress presents in clinical encounters? What cues and strategies are used by the family physicians? Again, we focus on family physicians. It could have been other primary care providers, but what are the cues and the strategies that they use? And how can we train the primary care providers better to do? We're here. So we've done our clinical questions, we've done the literature review. Well, I say we, but Maddie did most of the literature review. We have the team, we got some funding luckily from the St. Mary's Research Center. We did our interviews with the family doctors. We have the analysis of what we found. That's what we're going to talk about now. And now we're going to we're creating a teaching module for the family medicine residents to try to pass the knowledge. So lots of large words for people that might not be into the research setting, but a qualitative study means that we're talking to people and we're getting the narrative. Like I was saying, I'm really someone who really likes narratives and stories. So that's the way we build this, the study, talking to people, asking them questions, not like getting numbers and adding them, but really talking to people, trying to get, what their sense are of the work they do and how they do it. The snowball samplings is basically, you find someone who's a medical, like an expert, you ask the colleagues who's a good person for that, and then you interview that person and you ask that person, who else do you think we should talk to? And you do that until you have all the same data that comes, over and over again. That tells you that you probably figured out most of what you needed and the data is saturated, right? So we did that and we ended up interviewing 12 people in depth, like hours long interviews. So the interviews are one-on-one, mainly with the research assistants. Madison did most of them, and Anna Mareva did a few. And then there was the framework where they really look at what themes were coming out of the interview. So there was an interview grid, but it wasn't like questions where people would answer 1 or 2 words, right? They were answering, a lot of things, and then they had to figure out a way of coding the data. So if everybody said the same word, then maybe that was a theme, and they will look into the theme and see what was said about that specific thing, and we'll go back to the themes we found. And we were trying, because when we teach family medicine residents, we use a method that's called a patient-centered method, which is a way of really focusing on the patient to try to get their perspective on what they're going through in terms of pain or in terms of suffering, what they would want, what would be like their wishes about their medical care, all of that. So to really be centered on the patient. And we tried to see if we could put the information we were getting with the interview with the patient-centered method. And we can talk about it a bit more at the end. It kind of worked, but didn't work all that much. So we can explore that a bit later if you're interested. So the findings, so these are a few extraits of what people told us when we asked the questions. In terms of, there's 2 different people. So one person says, well, when they tell us that they have pain all over the body or headache, it's often they're telling us that they're distressed. And the way for me to know that it's maybe more psychosocial distress is because they're talking about all the time or very intense. That often tells that specific, expert family physician that maybe we have to go and dig a little bit more on the psychosocial distress. Maybe there's something more than something that's a very simple, like physical pain. The other one is giving advice on maybe you don't go right away and say, oh yes, you have too much pain, well, this is anxiety, but to really go step by step, right? These are words that are often for anyone, very charged, right? To talk about anxiety, depression, mental health, psychology, psychiatry, all of that. They're very strong words for anyone, but in different cultures, it could be even worse. So to be careful and to really go step by step when you talk about that. So amazing analysis that was done mainly by Nadia again was really to find 3 kind of cues or strategies that the physicians really use. The first one is to just ask about the culture, right? So I'm not sure what you mean when you say too much pain. Does that have, a meaning for you, or in your culture, this or that, is it linked for something? So to actually acknowledge that there's a cultural difference and ask about it explicitly instead of kind of stepping around without asking the question. Pleading ignorance to elicit narratives. So when you've cared for enough people that had too much pain, doctor, you sometimes get a bit of a sense of what's going on, but not assuming anything and just saying, well, I'm not sure what that means. Can you tell me really what that means for you? Or what's your experience about that? And not, as physicians often will come up with, we know everything and we're going to fix you, but sometimes, just taking a step back and being very humble in the way we ask questions and we ask people about what they're going through is often a very good technique that we use. And then finding the shared humanity with the patient, because often, again, depending on how big the cultural distance is, sometimes it's hard to find like common points or things that you have in common with the patient, but we're all human beings, right? So one of the person was saying, well, I talk about my kids if someone has kids, and that helps us to kind of find shared humanity. We talk about hobbies, we talk about this, we talk about that, but we find something we have in common to make it easier to talk about the harder stuff like the psychosocial distress, to really talk about the shared humanity. The pleading ignorance would be, let's say, so if you don't ask why is this happening? Why do you think this is? Why? What do you understand about it? Then you're going to wander around in the universe doing 10,000 unnecessary investigations and not help anybody, right? It's all in the why. Tell me about it. Tell me why. Tell me what you think. So asking the patient, and it's interesting because when we teach communication to family medicine resident, we tell them to do that, right? We tell them to ask what the patient is feeling, what are their expectations, what are, what their fears are, all of that. We teach them that, but it's sometimes easy to forget about it when you're in a clinical encounter that's a bit harder. So if there's a psychosocial, if you feel that it might be a psychosocial distress and there's some cultural difference, then asking the why is really, really helpful. I went the other way, there we go. So the three strategies that we came up with analyzing the data, the first one, the most important, is to really investigate appropriately what's going on. So if someone has a headache, it doesn't mean that people need an MRI if they have a headache. They need to have a good history taken, they need to have a good physical exam done, and you have to think about the different diagnoses and see how you can rule them in or rule them out, making sure you do that. Do not assume that because someone has too much pain or swelling in the head or the fever without the temperature that, it's all in their head. You can't do that. You can never do that, right? So you have to go through the appropriate clinical process and do all the investigations that you feel is necessary. But there's not always that many investigations that are really necessary, right? Sometimes people feel that for headache, you need imaging, or for back pain, you need an MRI. You don't always need that. You need to do your good physical exam, your good history taking, and you take it from there. Then talking about the practical aspects of well-being. Someone has a lot of pain and they're not doing so great psychosocially, make sure they eat, make sure they sleep, make sure they know about, breathing techniques or other techniques to help them kind of calm down is something that's really, really helpful. And we struggled a little bit with that one. We called it adopting appropriate authoritative strategies. In a lot of the interviews, people were saying, there's a moment in these encounters where sometimes you kind of have to tell the people what you think it is and what to do. So we, again, teach a lot the residents about, shared decision-making, and you give options to the patient, and the patient kind of decides from the options, which is a good way of practicing medicine most of the time. But when people are in a lot of distress, or when people come from a culture where the doctors don't really do that, the doctors kind of tell you what to do a little bit, sometimes give them a frame, like an encadrement is actually better and more helpful. So you can't do that all the time, obviously, but in an appropriate clinical setting, saying, well, there's multiple things we could do, but I really think in your case, maybe you need to have a week off work and take time to sleep and take time to do this and that might help for your headache, is actually a strategy that people felt works really well. So it's a bit difficult. Again, these are all very subtle things, not that easy to teach to family medicine resident, but it's actually something that has been for pretty much all of our experts, I think, mentioned it at one point or the other, that at some point you just have to, tell people what you feel they should do. Obviously, you don't stay too stuck with it and you negotiate afterwards, but sometimes it can actually alleviate anxiety or stress if you make the decision, right? Because making decisions all the time is also something that's quite stressful. So the authoritative strategies, like if you look in the one in English, I will be patient-centered, recognizing that the patient is from a culture where the doctor decides. There are times where people want to be told what to do, right? So you see it in an open way. I don't want to make it. I'm not sure here to make the decision for you, but I think that, yeah, maybe in your case, antidepressants would be helpful. So these are all excerpts, like everything we have on those slides are excerpts from an actual interview. In French, it says basically that sometimes you tell people, what do you think is going on, or how do you think I could help you? And people say, well, I don't know, you're the doctor, you tell me, right? And that's an answer you hear quite often. So to take that as a sign that maybe you need to be a bit more firm in what you suggest you do, keeping an open mind that, things might change. So talking a lot about the gut feeling right now, but what we struggled a little bit and where we have some data, but maybe not as much data as we would have liked, is we're trying to get at those doctors, when do they start thinking that this is maybe something that's more psychosocial, that the headache, the back pain, or the fever all over the body, how do they notice that maybe it's something that's more psychosocial? So as we mentioned before, Sometimes it's because there's, you know, a lot of intensity, someone who's quite functioning, but who's telling you that they have so much pain, they can't do anything, or it's all the time, or it's super intense. And the vague complaints together. If you notice that, especially in a transcultural or intercultural setting, then maybe it's a time to take a bit of a step back and think about the cultural humanity and ask people, you know, well, what does that mean to you? Or what do people do usually when they have the too much pain? What do you think would be helpful, and see how the patient reacts to that? Because that would be most likely a flag that maybe there's something more psychosocial. So what we found basically is the family physicians have both explicit and implicit strategies to elicit cultural and gender perception of psychosocial distress. I didn't talk too much about gender. It was quite interesting that it was easier to get physicians to talk about the difference in culture and not so much in the difference in gender. And there was this expectation that you really have to treat both genders exactly the same, and people were a bit more uneasy expressing, you know, if there were some gender differences in the way they treated patients or the way they felt towards the patient. So that might be for another study later on. It was very clear, and I think for everyone, that you need to be very nuanced in the way you have this approach. This cannot be like one grid and you just have 3 checkboxes and this is how you do things. No, you have to be very nuanced in the way you approach the patient's narrative and what they're feeling about their psychosocial distress and their pain. And we could use some of what those physicians told us to actually maybe change a little bit the way we teach patient-centered method, and maybe add a little thing about intercultural differences, because it's not something, I mean, it depends which med schools, which residency, but it's not something that's explicitly taught, right? Again, a bit like for patients that are like the gender thing, sometimes it's not always easy to say, well, sometimes there's cultural differences and you have to know about them and need to be prepared to work, you know, with that. Sometimes the medical system and the medical education system wants to treat everybody exactly the same way. And it's, you know, in real life, it's not the way things are. Yep. So the limitations, there's actually a quite limited pool of experienced family physicians in intercultural care in Montreal. It didn't take all that long to have all the same names coming, you know, over and over again. So there is some expertise, but maybe there's something to do in terms of maybe networking or getting all these physicians to talk together to maybe help, you know, training family physicians and all of that. And the other thing that was really, really difficult is, as doctors, you don't think so often about how you interact with a patient or what's your thought process when you see a patient. And when you're asked, well, how do you do it? When there's an intercultural, you know, how do you do that? It's actually not easy on the spot to really think explicitly about what implicitly you do. So that was one of the limitations. And maybe if there's a follow-up to this study or if there's other things we do, we might want to try to get family physicians to think a bit more about it before we do the interview. And the part 2, which I'm not going to talk too much about because part of it is not in the open yet, but we're going to work on a training module for family medicine residents. So we're going to work using the qualitative findings to try to feed into the clinical teaching that we give to family medicine resident. And we hope to pilot something very soon, see if it actually changes anything and if it helps, you know, in terms of patient care. We're hoping to get some patient input as well, because we did not get patient input up to now, but the plan is to get it for that second step and see if we're actually able to teach something from what we learned in that study. And that's it. We also feel after having done a short study that maybe our teaching module or maybe some other way, but there should be more formal training for family medicine residents into, you know, intercultural and transcultural care, because it's something that's very important and that we're not always trained. So again, as I mentioned before, some people are very good very rapidly with it. Other people struggle with it a bit more, and it's often because of lack of training. And, you know, if you individualize what you do and you use a nuanced approach, you can avoid stereotyping patients as much as sometimes happens. Because one of the other issues, and maybe I'll finish with that so we have time for questions, but Sometimes intercultural training or transcultural communication training is basically a list. If a person comes from here, this is what they're going to say, this is what it's going to mean, right? If someone is from First Nations and they say this, it means that you have to do that, but this is not the way it is. Yes, of course, cultures see things differently, and the way, as I mentioned again with the crise de foi, the way you're brought up gives you the impression that you can get a crise de foi that actually exists, but this is not, this is very, very general. And when you see the patient and when you interact with the patient, the more you know about them, the better you're going to be at not being stereotypical. And we have to move away from this sometimes training that is sometimes given in family medicine or in medical school of a very like black and white approach to intercultural care. That was for the gender. As I mentioned, it was a lot harder to get the physician to mention that the gender had an impact really on the encounter. But we feel that it might have been, again, because rapidly we asked them about that, and maybe they didn't have time to reflect, and it maybe is less, it's harder sometimes to say, well, yes, I don't treat women and men differently, right? Because this is not something that you're supposed to do, but it might be something that you do. So we'll have to figure out how to go and scratch that a bit more. And that's, so further studies would be for the implicit biases. So what do we have in terms of biases that we don't really know so much about when you're asked about it, and things you have to reflect on a bit more. So could we maybe explore that a bit more? And then maybe, you know, there's no real guidelines, and guidelines are something that are sometimes helpful and sometimes very harmful. So we'll have to look at that. But could there be a way, maybe with a network of physicians that are doing more intercultural care, to actually give some sort of guidelines or framework for intercultural mental health care? I think there should be more exposure and training, and the next work, as I mentioned. I know that's it. Are there any questions, discussions?
I'm just bringing that out.
Ah,
I have so many things to say. Go for it. Want me to break the ice?
sure, go for it.